Returning to normal will require many things to happen. Key among them, finding treatments for COVID-19 sufferers. And it turns out those who have already had the disease may be critically important to that search. With us now for more, in Vancouver, British Columbia, Dana Devine. She's Chief Scientist at Canadian Blood Services. In Hamilton, Ontario, Dawn Bowdish, Canada Research Chair in Aging and Immunity and a professor at McMaster University. And here in the provincial capital, Dr. Jeannie Callum, transfusion medicine physician at Sunnybrook Health Sciences Centre and a professor of laboratory medicine and pathobiology at the University of Toronto. And we're delighted to have the three of you on our program tonight for an important conversation that focuses less on how we got here and more on how we're going to get out of here. Dawn, I want to start with you because you're an immunologist, and I wonder if you could start by just sort of explaining what scientists know so far about the immunology of a virus such as COVID-19.
Yes, absolutely. The answer is we're still learning. Of course, this is a new virus, but if we think of immune responses as coming in three major flavors, the first one being chickenpox. You will have had chickenpox as a kid, and for most people, most of the time, you're protected for the rest of your life. The second flavor is something like tetanus shots, as an example. We do generate really strong, robust immune responses, but they don't last very long, and that's why we have to go back again for boosters every 10 years. The third flavor is actually our immune response to viruses like HIV. As it turns out, people living with HIV have robust immune responses. They generate a lot of protective antibodies, but those antibodies don't stop the infection. And when we mimic those antibodies by creating vaccines, they haven't been able to prevent infection. So when we think of the SARS-CoV-2 virus, we want to know which of those three flavors of immune response are we going to get. We hope and pray for the chickenpox answer, that people who've been sick today will be protected for the rest of their life. We fear the answer will be more like the HIV story, where you may not necessarily generate protective immunity. But based on studies of related viruses, we expect it to be like tetanus. We expect that there will be some period of immunity where people are protected, but that may wane with time. And that, unfortunately, we only can learn with time as we follow people who've been affected over the course of months to years.
And Dawn, let me do a quick follow-up with you. This virus seems to be obviously much more problematic for people who are older. Is there some reason why their immune systems seem to be responding so much differently than those who are, say, under the age of 80 or 70?
Absolutely. So the aging immune response has a few deficiencies. We tend not to be so good at generating brand new immune responses as we get older. We do think that a lot of the age-related susceptibility is not so much due to chronological age, but just the frequency with which people would have those pre-existing conditions we've heard so much about, the hypertension, the cardiovascular disease. But we've also found some very odd and disturbing findings in some of the early studies that have come out of China. We know that people who become very, very ill, so ill that they're hospitalized and then die, tend to have some strange changes in their circulating immune cells. Some of the immune cells called T cells that we would expect to be in the blood aren't there anymore. And it looks like in some people, they might be going to the wrong places. They might actually end up in the lungs. And if this is the case, then we would predict that they're adding to the damage that the immune system is causing instead of being protective. We suspect that as we learn more about how the aging immune response responds to this virus, we'll also learn a lot about how it's causing some of what we call the pathology or the harm that happens as part of the immune response to the virus.
Jeannie, take us through the next part of the story now, which is that the people who have contracted COVID-19 and come through it, they are believed, I gather, to have some kind of, well, let me just say it facetiously, some kind of superpower right now, right? They've developed antibodies. How are you hoping to channel those antibodies into helping others who are facing the COVID crisis?
Okay, so what we're going to try and do is really bridge until we have a vaccine. So trying to take patients who have recovered, they're somewhere between 28 days from recovery out to 12 weeks after their recovery, and that peak where they're going to have very high, strong immunity, strong antibodies. We're going to collect their plasma, which is the liquid part of the blood. We're going to collect it with a special machine that really only takes about an hour to collect it. It's quite easy, painless. You can read a book while you're on the machine or watch a movie. And donors can donate up to once a week. We freeze it away. We test it, make sure it's got nice, strong antibodies. And then we take it to the hospitals that are participating in the trial. And we've selected to try and take patients who are sick enough to be hospitalized, patients that just can't seem to get their immune system to respond fast enough so that they can weather the storm at home. But they're not sick enough that they're in the intensive care unit. And we're going to compare in a clinical trial where we randomize patients, where some patients, the computer decides that they're going to get this special super plasma compared to they're just going to get regular hospitalized care, and whatever else their clinicians are going to offer them to try and make them heal faster. And we're going to compare the two, and we're going to measure lots of outcomes on these patients, and we're going to try and figure out, does it make them get better faster, less likely to need ICU care, less likely to die, spend less days in hospital? Does it clear the virus quickly out of their system? So we're doing lots of different measurements, and we hope for once this is kind of like a holy grail of immunology. People have tried this since 1918. To see if convalescent plasma would work. Now we have this opportunity to answer it, and at the same time help Canadians and put Canada on the scientific map for answering this question.
Okay, you used the term there, and I'll get Dana to pick up the story. Convalescent plasma. Do we need a definition of what that is?
So convalescent simply refers to someone who's recovered from an illness. And so convalescent plasma is the plasma that we collect from people who have recovered from COVID-19 disease. And as Jeannie was explaining, we want to wait a little while after they have recovered because the quality of the antibodies that they'll have in their plasma is better at fighting the virus if we wait a little while.
We've got a clip here that actually shows how that collection takes place. So let's run that clip and then we'll come back and chat.
This is just a one needle process.
What is the machine doing?
So right now the centrifuge is spinning at 7,000 RPMs. We're separating your red cells from your plasma and collecting it off in the front bag. And in a minute here, we're gonna have a return, so you'll get your red cells back through the same needle.
Okay, Dana, maybe you could pick up the story from this angle. The fact that we're in the midst of a global pandemic right now, does that change the way in which plasma is either collected and or donated for the purposes of this trial?
Not at all. So we're going to be doing our plasma collections at Canadian Blood Services, and our sister blood operator in Quebec, Quebec, will be doing exactly the same thing we do when there's not a pandemic. So when plasma donors come in, they get attached to the machine that you just saw in the video clip. It takes about 45 minutes for us to collect a plasma donation using that machine, but we give you all of your blood cells back, and all white cells and your red cells and your platelets go right back into your circulation. And we're simply collecting that straw-colored liquid you saw in the video.
Do you have a preference whether it's men or women who donate?
For this clinical trial, we're collecting from men who have recovered from COVID-19. And the reason that we're doing that is because we want to make sure that we don't put into the hospital clinical trials plasma from any women who may have antibodies that could actually cause more lung damage. And that occurs in women who have had a history of pregnancy. And so just to make sure that we're not going to make the situation any worse, we initially are collecting plasma only from male donors. If the clinical trial proves to be successful, then we will be looking at collecting plasma from anyone who has recovered from COVID-19 who is willing to undergo plasmapheresis procedure and for whom undergoing that procedure would.
And one more quick follow-up here. If you're a Canadian who's had COVID-19 and you've come through it, could you donate your own plasma directly to somebody of your choice, a sibling, a spouse, a relative, something like that?
Yeah, we're not doing that. And the reason is because very often plasma will contain antibodies against red blood cells. And we don't want to give you an incompatible transfusion just because the plasma came from your husband. So we're concerned about the compatibility, and so we're not doing what we would call a direct donation. We're putting everyone's plasma in the pool, and that way you get the compatible plasma that's needed for that.
Gotcha. Jeannie, when else has this treatment been used over the past century in this way?
Yeah, so it's been tried for influenza back to 1918 in what we call uncontrolled studies, where you take a group of patients, you treat them, and you compare them to people that didn't receive the treatment, but it wasn't a clinical trial where patients are randomized. But it was also tried in SARS in a small number of patients, in MERS, which was a similar coronavirus. And even in the COVID-19 pandemic, there have been small case studies of treating 5, 10, 20 patients, and it looks promising, but we really don't know because no one's ever really tested in a properly designed clinical trial where we're actually measuring and we're knowing we're not doing more harm than good.
It's interesting, though, that this actually dates back to the Spanish flu. This basically what you're trying right now was tried 100 years ago.
That's right. And really, we use concentrates of antibodies for other infections where you get exposed. So if you get exposed to measles, and for whatever reason we can't vaccinate you because your immune system's compromised, we do give you antibodies from other people from their vaccines, and it works to prevent the infection, make the infection less severe. So there's a lot of historical evidence to suggest that this should be an effective therapy.
And what is the sweet spot in terms of time? Once you've had COVID, once you've passed through it, what's the best amount of time to wait for when your antibodies are the strongest and able to do the most?
Yeah, so we think it's going to be somewhere between 4 weeks to 12 weeks after your infection, but we're going to be measuring the antibody levels in the donors. Hopefully, they're going to donate every week as long as they're healthy, and that will allow us to measure how strong the antibodies are over time, how fast do they drop, why do some donors have higher antibody levels than other people? Is it related to how strong their infection was? Were they hospitalized? So I think we're going to learn a lot, not just on the patient side, but also on the donor side about these antibodies.
Gotcha. Dawn, I want to ask you about another rapid response antibodies test that was apparently made in Ontario, but then shipped out internationally. The US, the UK, and I think some European countries are allowing it to be sold, but apparently we are not there yet. What's the test and why not?
Yes, so some of these commercial assays are useful, but you have to be really specific about the question you're trying to use for them. So many of us in the immunology field, and certainly public health, the government, are really interested in knowing two things. If you have antibodies in your blood, you have had an infection. Maybe you were symptomatic, maybe you were asymptomatic, but you've had an infection. So we can use these tests to understand how many Canadians got infected or how many people living in Hamilton got infected, that sort of question. The second use for these sort of tests is to determine what we call back to work readiness, or you may have heard of an immunity passport. And that's used for very different reasons. So the idea is that we'll be able to look at, especially at high risk people, think emergency room nurses, that sort of thing, determine if they have some of this protective immunity, and then maybe shift job responsibilities around so that people who have protective immunity are doing the more dangerous or risky procedures, whereas people who haven't been infected are not. These two different applications require two different specificities and sensitivities. Imagine if you were that I wanted to know how many people in Hamilton had been infected. If we tested 50,000 people in Hamilton and found that 1,000 had been told that they did not have the infection, but they actually did, and 1,000 had been told that they had had the infection, although they hadn't, that wouldn't change too much. Accuracy is obviously preferable, but I would still come to the same conclusion about how many people in the area had been infected. But now imagine I'm telling that healthcare worker who's at extremely high risk of getting sick that she has protection when she doesn't, or it doesn't have protection when she does. That could have really negative outcomes. We could be putting her at risk by redeploying her to a riskier situation. Or if people changed their behavior because they felt they were immune, they felt they didn't have to do social distancing, wear masks, or they decided to go back to work early, that could help with the spread of infection. So the tests that have currently been approved by the FDA and elsewhere have very high false positive and false negative rates. And for the kind of testing that we want to do right now about deciding, making personal choices that might affect the health of individuals, I personally wouldn't want anyone I cared for to make a decision based on those tests. They might be okay for larger population studies, like I said, where no individual is going to change their behavior or their risk isn't going to increase, but I certainly am very wary of that. Unfortunately, we do have better tests that are more specific and more sensitive, but they're slower. So in these sorts of compromises that governments have to make, you have to choose between cheap, fast, and well done. And unfortunately, some of these rapid response tests have sacrificed the well done angle to it. And I think the Canadian attitude of requiring a bit more sensitivity and specificity is probably very wise for making personal decisions. And we can then make better decisions about population-based studies by generating accurate but cheaper assays to look at antibody levels.
Dana, beyond the rapid blood test that we've been talking about, are there any other effective tests that are available to the Canadians now who want to know whether they have built up some kind of immunity to COVID-19?
Well, I think as Don was just explaining, there are a lot of companies out there now that are working to develop tests that can be used either in a rapid test format, as we were talking about, or tests that can be used on big high throughput machines. And the companies that are developing those tests are working hard to increase the sensitivity and specificity issue so that if you get a positive test result, you'll actually know that it was related to this coronavirus and not to some common cold coronavirus that you had 3 months ago. And so we're not quite there yet, but there's really a lot of activity going on developing these tests, and we will be there.
Don, let me go back to you with this. Some people have argued that we should be building up this so-called herd immunity, and therefore maybe it's a good idea to let a lot of younger people, who obviously will not have, chances are, serious and adverse consequences to contracting COVID-19, let them build up the antibodies faster. They can get the virus. They're highly unlikely to be killed or seriously damaged by this. What's your view of that?
Well, in truth, I mean, going back to my chickenpox analogy, imagine if you would, every child under 10 got this virus, they had a week off because they had a fever and weren't feeling well, or maybe they were asymptomatic and they were protected for the rest of their life. It sounds lovely, but it's a fantasy the way our societies are structured. And think even now about how we've all been very compliant to our social distancing. Canadians have really listened and responded to our public health measures, and we're still having massive deaths in our most vulnerable populations. In Ontario, we've seen huge outbreaks in nursing homes. So this idea that you could somehow manage this infection in such a way that only young people would be able to get it and we'd be able to protect the more vulnerable members of our community is a bit of a fantasy. I think as well, what we don't understand about this virus now is if there are going to be long-term health consequences to having it. Certainly, we know that having a pneumonia serious enough to get you hospitalized as a middle-aged to older person can accelerate other health conditions. And there's no reason to think COVID-19 wouldn't be the same. So although I am, of course, sympathetic to the fact that people's jobs are on the line, our economy is shut down, our social lives have been affected for the worse. I think what we need to be aware of is we cannot create a system in which we only infect young people and don't put their grandparents, their aunts and uncles, their teachers, the rest of their community at risk. And for that reason, I'm not supportive of trying to generate herd immunity, because even in our very social distancing we have now, we're still seeing a huge loss of life in our more vulnerable populations.
Right. Dana, let me go to you on this one. Other countries, including the United Kingdom, I'm told, are considering something we referred to earlier, these immunity passports or certificates, and they'd allow people who've recovered from the virus to sort of, reopen their lives, resume their normal lives, and help restart the economy. Do you have a sense about what that might look like if we were to try that in Canada?
Well, I think to go back to what we were discussing earlier, the first thing we need is an accurate test that can actually tell us which proportion of the population is actually protected, has immunity, and could get back to work. There's clearly a lot of people who have never been tested, who have had symptoms that may or may not have been COVID-19. and they all need to be evaluated and understand whether they would be eligible. I think that it's a very different thing to do in Canadian society. I think you would be walking around with quote unquote paper. Sort of feels like something very new to us, and it would be probably more than a sticker on your driver's license.
Yeah, Jeannie, it does feel, I mean, I don't want to overstate this, but it has some authoritarian aspects to it. But on the other hand, if there were a way to sort of gradually reopen our economy by allowing those who have this so-called immunity passport to get back out there and lead a more normal life, do you think that would be advisable?
Well, I have to agree with Dana's comments as well. The other thing is we don't know how long that immunity is going to last. So what are you going to do? Test people every 3 months, every 6 months to determine if they still have immunity, and then take away their passport when their immunity drops off until they get reinfected again and then test positive again. It seems excellent in theory, but I think we're a long way from something like that.
Dawn, what's your take on it?
Although theoretically, I can definitely see the utility, and certainly everyone I speak to wants to know. They want me to test their blood because they want to know if they had COVID. I completely agree that we don't know how long, or even if everybody who generates an antibody generates a protective antibody. So going back to my HIV analogy, some people may be generating antibody responses, so they get a positive result on those tests, but those antibodies might not be as protective as we think. And the unfortunate thing about this virus is we just need more time to understand it. We need to know what we call the immune correlates of protection, and then we'll be able to make really informed decisions about who is safe to go back to work, who is safe to go back into their community, and who isn't.
I know you want more time, but I don't know if you saw the Prime Minister's briefing earlier. He had to fend off numerous questions from reporters who were, who I guess are asking on behalf of the population of Canada, how much longer are we going to have to do this? Premier Ford said the other day, people are getting squirrely. That was his word, squirrely, about having to be in self-isolation for so long. I wonder, Dawn, whether you folks who do what you do are feeling the pressure to come through with something sooner rather than later, because one doesn't know how much longer the Canadian population is going to play ball with these protocols.
No, there's a real concern that we might have some aspect of fatigue with social distancing for sure. And obviously the economic consequences are huge and they're going to be long lasting. I would say I've never seen the scientific community move so quickly and so compatibly together. Everyone wants to be part of the solution, not part of the problem. Unfortunately, you can't rush time. And so if protective immunity only lasts for 3 months or 6 months, well, we've only had 6 months or 3 months since the Chinese outbreak. So we're really learning from them. And then the Italians are going to share their data with us, and we'll learn from them too, and the rest of Europe, and we'll learn from our American colleagues. So there's a huge community of scientists all sharing information, sharing protocols, sharing details about how we're going to deal with this. And so science is working as quick as it possibly can. But I just want to echo my colleagues. We have to have good, specific, precise tests to give people the information they need. And unfortunately, there's nothing that can replace time to do things right.
Well, forgive me, Jeannie, but I am going to ask the question about time. How much time before you think you will know whether the treatment that you are helping to test is successful, and for whom?
Okay, so we're moving very, very fast. Normally, it would take us a year to 2 years to launch a clinical trial. We would normally do a pilot trial, make sure we've worked out all the bugs of the clinical trial. And instead of being 1 to 2 years, we've dropped that to 4 weeks. And we hope to have our first donor, first recipient in the next 2 weeks. We've ramped up things very, very fast, and every single hospital, university, Canadian Blood Services, Hema-Quebec, Health Canada, everybody is working at lightning speed to make this happen. So we are planning for 1,200 patients to be in the clinical trial, and we hope to have an answer sometime by the end of the year, early 2021.
And how are you able to crunch the clock so much?
Things that would say normally take a year to come up with a protocol required probably about 100 people working straight for 2 weeks to develop that protocol. We had meetings twice a day, and then that went through weekends, long weekends. There has been no rest for anyone in the transfusion medicine, infectious disease, ICU as part of our team. And basically, we're working people at 40 different hospitals very, very hard.
And Jeannie, just finally, what other questions are you hoping to answer through this study that might help those who are facing future pandemics?
We're trying to answer the question of whether convalescent plasma will stop people from needing intensive care, stop needing to go on a ventilator, and that has huge impacts on the patient, but as well as just the healthcare system in general. And we're also trying to figure out who are the best donors and who are the best recipients, the people that are going to benefit the most from this, by looking at different subgroups of patients. So I think we're going to learn a lot from a whole bunch of different analyses on the patients that are going to be participating in this trial, both on the donor and the recipient side.
Well, needless to say, the whole country wishes all three of you well in your work. That's Jeannie Callum from Sunnybrook Health Sciences Center, and we also thank Dawn Bowdish, the Canada Research Chair in Aging and Immunity at McMaster University in Hamilton, and Dana Devine, the Chief Scientist at Canadian Blood Services in Vancouver. Good of all of you to join us on TVO tonight. Thanks so much.
Thank you.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.